Thank you. All right, I'm the last speaker for today, so I don't want to stand between anyone and their meal and cocktail hour tonight, so I'm going to be fast. Okay, so my name is Shalini Shah. I'm from UC Irvine. I started the pediatric pain program there about 3 years ago, and I'm going to talk to you a little bit about treating pain in children. It's interesting because everything you've heard today, we're going to tie it together kind of today, because I think what Dr. Bergman spoke about, Dr. Barco spoke about, Dr. Beard spoke about, every one of us kind of feels the same way, and we treat patients with the same philosophy. So it's going to be a kind of a comprehensive tying everything together tonight. So in children, what does pain look like? You know, most children in pain, sometimes it looks like a benign cause to us, right? Oh, my head hurts a little bit. I got an owie at school. But in some kids, that very benign presentation actually looks and feels like terror, you know? It's like walking on coals, electricity. They don't have the tools to describe what they're feeling, right? So it's up to us to try to tear apart what the presentation is. Sometimes, even the smallest, most innocuous stimulus like a feather can cause a tremendous amount of pain in these kids, as you probably know because of RSD. So I'm going to give you a patient of mine that actually Dr. Bergman and I, our physical therapist, treated together. I've changed her name, but Jenny was a very energetic 13-year-old girl. She went to ballet class. She probably fell down from a pirouette, had a sprain, didn't even realize it. She complained to mom, you know, I fell, I don't feel so good, the leg hurts. She went to the pediatrician, went to the urgent care. They said it's just a sprain. They wrapped it, said the sprain healed. Then over the next 2 years, the pain came back. And she went from doctor to doctor to doctor. I think she told us she went to about 8 or 10 physicians until she finally came to us. But everyone did a full comprehensive workup. Orthopedic surgeon, the rheumatologist, blood work, x-rays, everything came back negative, right? So she went from doctor to doctor to doctor, finally was referred to a pain management specialist and was diagnosed as complex regional pain syndrome, RSD. But the issue comes back to, how can the brain perceive this so wrong? How did the pain get so out of control? It was a minor injury. How did it get this bad? One of the things I try to explain to her is that pain is a protective mechanism in our body, right? When we touch a hot stove, it's protective for us to remove ourselves from that stimulus, right? As we get that stimulus from our hand or our foot, the signal translates up into the brain and the spinal cord, and then ultimately to the brain, the somatosensory cortex, for processing. But if we understand the human body and signals as only as signals in the body, then we're misunderstanding pain, right? We have to understand it in the conceptual framework. This is a child, this is a female, this is a girl with a lot of anxiety. She was a straight A student. She was a high overachiever type of student. You know, she had a lot of stressors already in her body. So we have to look at her not just from pain signaling, but also a lot of other factors, psychological factors as well, to understand her pain. And the reason it's so important to understand pain in children is because when I see adults, I do adult pain as well, and they have chronic pain from whatever the cause may be, they're out of work, right? It's an economic disability, it's an economic factor, right? We're not able to be in the workforce. But for children with pain, they don't end up going to school. They miss a lot of classes. They don't graduate on time. They're not able to go to college on time. And so what happens is that they don't fulfill their own potential in life, which is much bigger than any economic disability, right? So that's why it's so important for us to treat pain in children and treat it well and find out the causes of the pain early. So let's go back to Jenny. Okay, she was diagnosed with CRPS eventually. She came to us, we did a full physical exam. It was very clear. She didn't have to say more than 5 sentences. We knew right away what this was, right? That's because we see it every day. She had the nerve pain, the skin color changes, the temperature disequilibrium. But what happened to her was that it was not just pain. Pain was just her symptom. The pain became a disease in and of itself, right? It overtook her. She was not able to go to school. She fell out of her ballet class. She was a top-notch ballerina to go to the American Academy of Ballet. She was not able to fulfill her own potential. So in kids, most of the CRPS is traumatic. It's usually in the lower extremity because kids are on the soccer field. They run during soccer, they fall, they trip during recess, things like that. So it's usually in the lower extremity, mostly from a fall that they don't even remember happening. It's rare before the age of 8. I had a child, the youngest I've ever treated was, I think, 7. I don't know about Dr. Chopra, how young his child was, but it's rare before the age of 8, CRPS. Like I said, it's usually the lower extremity more than the upper extremity, and about 20% of cases can become bilateral. So while it may start on the right leg, it may also go to the left leg in 20% of the cases. So this is actually, I believe this is her photo on presentation, okay? This is bilateral presentation. You see that, right? You see the swelling of the extremity, you see the atrophic changes of the foot, you see look at the nails, you see the nail changes. This is classic, right? This was 3 weeks, week 3, after therapy, physical therapy. That's it, okay? You still see the changes of the skin and the nails and things like that, but doing pretty well. This is week 6, okay? This was her, and she was able to even get a pedicure, okay? 6 weeks after diagnosis. And this was her at week 12 in the office. So she brought her ballet clothes and her ballet shoes, and she was showing me now she's on point, meaning she can go on the toes for ballet class. This is remarkable, but it's common. We can treat pain well in kids, okay? So let me talk a little bit about how we treat pain in children, how it differs a little bit from adults, and what are the strategies that we use. The first thing we have to realize that the effect of chronic pain is throughout the whole body. It's not just the leg that's broken or the hand that hurts. It's the entire body, right? So let's look at the metabolic responses. You have increased secretion of sympathetic hormones, neurotransmitters, right? We have decreased wound healing. We have poor intake. The patients don't want to eat as much, okay? So that can lead to weight loss, anorexia. They don't want to move. It hurts to move. They don't sleep. They don't sleep well at all at night, right? They're irritable throughout the day. Behaviorally, the children regress. They're cranky, they're crying, they find alternative modes to express their pain because they don't have the words that we do to express pain, right? They don't have that vocabulary that we do. So they regress. And what you have is, this is the simple cycle that all of us have experienced, and many of you have probably seen either in the textbooks or internet, is that pain, the chronic pain cycle. You have pain and you don't want to move because it hurts. And because it hurts to move, you can't go to school. So the school problems, your school attendance suffers. And then the children don't sleep during night. And then they feel withdrawn because Becky and Jason went to the mall, but I couldn't go, right? So they're not hanging out with their friends. They're not doing the things that usually should bring them joy and be with the other children. So they develop a sense of anxiety, sense of depression, and that makes the pain worse. And it's that cycle that continues and continues. So we have to break that cycle, right? So the focus is on rehabilitation, okay? It is physical functioning, social functioning, emotional functioning, and quality of life, okay? Yes, pain is what we're treating, but that's not the end point. The end point is really functioning, okay? And so what I tell my children is that it's going to hurt. You're going to have to go to physical therapy. It's not going to be fun. It's like studying for an exam, right? That's the analogy I usually say. You're studying for an exam, you hate studying for that exam, you're up all night, you have a lot of anxiety for it, but at the end of the day, you get your exam results and you got an A, right? You put in all that hard work and it was worth it. So it's the same thing. You have to go to PT every day. Mom is going to hate me because she's going to have to stay up all night with the child crying because it hurts so much after PT, but that's okay. Just because it hurts doesn't mean there's anything wrong with the body. You have to, like Dr. Bergman says, you have to retrain that brain. So what do I tell pediatricians or patients or moms? When is it time to see a specialist? You know, as a parent, you know when you're beyond, oh, something's wrong. You've gone beyond that stage. Or as a pediatrician, how do you know when to refer, right? And the bottom line is this when it comes to pain, is that pain is whatever the person says it is, and it exists wherever he says it does. And that's the bottom line. We have to listen to our patients, right? We have to listen to you. If you tell us you're in pain, that's the time to go to a pain management specialist and take it seriously. So what is our approach? Okay? So in the clinic, what we have try to accomplish is a multidisciplinary approach, right? We want to treat, obviously, the medical aspect of the pain, as well as the behavioral aspect with the pediatric pain psychologist, okay? And then the functioning aspect is what we need the physical therapist for. I don't have a pediatric pain physical therapist in the office, so I usually tend to refer my patients to Julie or someone who understands CRPS, who has done the homework and understands the disease itself, okay? So we start, we take a very comprehensive history and physical. I spend about an hour at least with these patients just by myself doing a history and physical. We go through everything, how they're doing in school, birth history, any stressors in the home, our mom and dad going through a divorce, things that could bring on stress in one's life. And then I refer them to our pediatric pain psychologist, and she also helps them dealing with the pain, coping with the pain, understanding what pain is, right? Because they don't understand. They don't have the cognitive ability to understand what pain is. And what we try to explain to the children is that there's a subset of patients that have pain as well as children with psychiatric disorders. It doesn't mean that one led to the other, or one causes the other, or children with psychiatric diagnoses are more likely to get pain. It's just that they coexist, and that's a fact, okay? So that's why we have our psychologist in the office to help with that aspect of treating pain, okay? We always give you a commitment to a therapeutic alliance. What does that mean? That means that we all talk together and discuss your care together, because that's important. What I see from most patients is they say, I go to this neurologist, and then I go to this rheumatologist, and I go to this person, and it's hard for us to connect to each other, right? To all the doctors to get on the same page and be the one person managing your pain. So this is what we do. We try to get all the doctors together, and we sit and we discuss. So even if it's your orthopedic surgeon, we pick up the phone and we talk to them, okay? And parents, what I try to say is that you can do the same thing. You do not need to get to the point where you feel overwhelmed with the pain, okay? There's a lot of things you can do. I'll give you an example. When I was living in Boston, my daughter, it was an unfortunate accident with a babysitter, but suffered a third-degree burn. She was admitted to the burn hospital in Boston. And, she had to go every day for those wound dressing changes that they do. It's a third-degree wound. And I myself was anxious. You could see me. I was more stressed than probably my daughter was. And one thing I realized is that if I could calm my own anxiety over the issue, over the burn dressing changes, which are typically very painful, she did much better. And it's true. If I was able to calm myself down, I could easily distract her. And she got through the burn dressing changes every day like a champ. So that's what I'm trying to say, that parents, you also have the tools that you can use to help your child. Distract them, take them to their happy place, whatever it is. Because distraction is a powerful tool for pain. Okay, what we want to tell the children is that you have to learn to function despite being in pain, okay? And they do remarkably well. So 10 reasons I say that we should always talk or consider a pediatric pain specialist is if the pain is greater than 3 months, the child is not functioning well, the child has been started on prescription painkillers, and we want to get them off these painkillers. Like I said, it's a detriment to their own potential in life. It's great for the short term, it may help, but we ultimately want to get them off of it. When you start to notice your child is withdrawn from activities, you've noticed that the anxiety and depression has started to set in, their school performance is declining, they're not sleeping well. You have gone from doctor to doctor to doctor, and you still have no idea of why your child is in pain, okay? When the pain persists, even though the original injury has healed, which is very common in CRPS, right? The pain persists even though the foot has recovered. So, and then when to refer when you think of it, okay? One of the things I want to talk to you is a little bit about some of the research that has been going on in pain management or CRPS or neuropathic pain. This is something that Dr. Bergman spoke about, which is the primary somatosensory cortex. It's how we perceive pain. When we injure our hand or we injure our foot, it goes through the spinal cord up to the brain and up to this area in the brain that's a map of the brain. So we know that the pain came from the hand, okay? So if you notice that the area of the hand and the fingers is right next to the area of the face. So a very interesting study by Herder Flor et al. From Germany looked at patients with phantom limb pain who had an amputation. Those with an amputation and had phantom limb pain, and those who had an amputation without phantom limb pain, okay? And compared it to healthy controls, healthy patients, okay? And what she realized when she put patients in the scanner, the MRI scanner, and asked them to smack their lips together, this is what she found, is that this is the area right in the middle of the lips, and the two arms represented. And all three are lighting up appropriately when the patient's asked to smack their lips together. This is in the middle is the patients with amputation without chronic pain. So their MRI scan looks similar to the normal, right? If you look at the patients with chronic pain, those who with an amputation with chronic pain, you notice that the arm that is amputated, that territory, that area is actually being occupied by the area with the mouth. Okay, so when they're asked to move the mouth, remember that mouth is right next to the hand, and that area is being overcome or taken over by another territory, meaning that there are actually chronic effects of chronic pain. This is the one thing I try to explain to other colleagues, is that long-term blood pressure, long-term hypertension has chronic effects in the body. Right? Long-term diabetes has chronic effects in the body. What about pain? Long-term pain has to have chronic effects in the body, and it's true. This is what the study has demonstrated. There are chronic changes in the brain. So what are some of the things that are coming up that we are learning about or should be using and we will be using in the future when it comes to pain management? As you know, Obama just committed quite a bit about money and NIH funding, or mandated the NIH give some funding for personalized precision management of chronic diseases. Have you heard about this? Precision management, personalized health management, meaning that we should be treating patients individually or using individual characteristics about patients to treat them. For example, if I give, for example, one patient 1 milligram of morphine, it may work one way, and given the same milligram dose to another patient, it may have no results at all, right? Because each body is different. And one of the things that we've realized is that we have to look at the genetic makeup of individuals when we treat patients. And in terms of pain, there are multiple portions of the genetic code where there are mutations. There are mutations in our genes that may alter our sensitivity to pain, may alter how we react and respond to medications. And one of them is different receptors in our body. For example, the COMT enzyme, which is in the brain, it's actually responsible for melanin production. It also happens to be responsible for how we process opioids. The ABCB1 transporters in the spinal cord, again, a transporter for opioids. The opioid receptor itself can have mutations, which is why some patients respond very well to codeine and some patients don't. Okay, so these are all the things that are in the pipeline. We're going to be doing a lot more personalized precision management, and that's a good thing. That's exciting. So when we look at someone with a specific trait, a specific presentation, we analyze their gene, their genetic makeup, and see, are there any mutations that could be contributing to why this patient is presenting this way? And then we treat them accordingly. It's pretty exciting. So the goals of pain management for children, okay, we want to obviously decrease their pain and suffering, promote a healthy family and family bonding, encourage physical functioning, make sure they're coping well with the pain. The pain may persist, but we can cope with it. We can deal with it on a daily basis, okay? And decrease our patients from complications. And success is on your side. One of the most important things I tell patients who come into my office, and the moms come into my office and they're distraught, and they say, will my child ever get better? One of the good things is that we have statistics on our side. So about 95% of pediatric neuropathic pain syndromes will resolve. That's 95%. Part of it is because the brain is plastic, right? The brain can adapt to change. The younger we are, the more adaptable we are to change. That's number one. But number two is, I've got moms and dads who are so compliant. They make sure they're there with every single physical therapy appointment, make sure those medications are taken on time. So they do really well. So that's really encouraging. So I know there's a mom in the audience who came up to me and said, my daughter was just diagnosed this week with RSD, and is she going to get better? And the answer is most likely yes, she will get better. We just have to put in the commitment. And that's it. And one of the things that I'm so excited about today when I came to this conference is that normally when we go to conferences as physicians or clinicians, it's doctors speaking to doctors. And this is one of the few conferences that I've been to where the entire audience, and most of the entire audience, is patients. And just speaking with all of you this afternoon, this morning, it really encourages us. You know, we have an entire support group here. A new mom came to me. My daughter was just diagnosed a week ago. And, you know, here we are, an entire conference room of individuals who can help her, support her, said this worked for me, this didn't work for me. And even for us to learn and grow from your stories is really amazing. So we are so thankful to be here. And that's about it. Any questions?